Okay, let's dive into this. Welcome to This Explainer. Throughout 2025 and 2026, we've been witnessing a massive, totally fundamental paradigm shift in oncology. We are officially leaving behind a century-old era of blunt medical instruments and stepping fully into the age of precision target selection and programmed immunological eradication. I want you to think about this mystery for a second. For decades, a lung cancer was treated as a lung disease. A breast cancer was treated as a breast disease. But the biology, well, it tells a completely different story. What if the geographic location of the tumor was far less important than its unique, microscopic identity? See, for over a century, our medical approach has been defined by three legacy pillars: surgery, radiation, and systemic chemotherapy. In the medical community, this was often colloquially and kind of grimly referred to as slash, poison, and burn. But look at the contrast with the new precision paradigm. We're now utilizing molecular target selection and programmed immunological eradication. So why does this matter today? Because it means minimizing the severe collateral damage to the human body while maximizing the absolute destruction of the disease. To truly appreciate how far we've come, we actually have to look back at the startling origin of modern chemotherapy. It literally began on the battlefields of World War I. Clinicians noticed that nitrogen mustard gas, a highly toxic chemical weapon, severely depleted white blood cells in soldiers. This blunt, incredibly toxic instrument was later repurposed by scientists to target lymphomas, and crazy enough, that chemical weapon became the baseline of cancer care we've been working from for decades, until right now.
Chapter 1: Diagnostics: Reading the Epigenetic Barcode.
Now, what's really interesting here is that long before a tumor is ever large enough to be visible on a physical scan, it actually sheds chaotic, microscopic DNA fragments right into the bloodstream. We're now leveraging a field called fragmentomics to hunt those fragments down, and this massive science is being deployed in the real world right now. In the groundbreaking NHS Galleri trial, over 142,000 people in England, who were entirely symptom-free, by the way, enrolled to test a multi-cancer early detection blood draw. We are finally moving away from waiting passively for symptoms, and we're actively hunting the disease at a microscopic level. So, here is how this technological marvel, known as epigenetic methyl-seq, elegantly works. First, we extract the DNA from the blood. Second, we apply a chemical bisulfate conversion. Think of this like using a special black light to reveal invisible ink. It perfectly preserves the epigenetic barcode that tells us exactly what tissue the DNA originally came from. Third, we use next-generation sequencing to read billions of genomic bases all at once. And finally, an AI pattern classifier analyzes gigabytes of raw data per patient to pinpoint if and exactly where cancer exists. And the results? 83%. Just let that sink in for a second. That is the sensitivity rate of the newly FDA-approved Shield liquid biopsy test for detecting colorectal cancer in average-risk adults. An 83% success rate at finding a primary cancer from a simple, routine blood draw. That is an absolute turning point in the timeline of global cancer care. Chapter 2: Treatment, Trojan horses, and bystanders. But detecting the disease is really only half the battle, right? To eradicate it, we rely on a biological phenomenon known as the bystander effect. Older targeted drugs only killed the specific cells that expressed a certain target protein. But the thing is, tumors are sneaky. They are highly heterogeneous, meaning some cells show the target while neighboring cells completely hide it. So the crucial point is how next-generation drugs fix this. They use a lipophilic or fat-soluble payload. When it enters a targeted cell, it's specifically engineered to leak and easily diffuse across the cell membrane, wiping out the neighboring untargeted cancer cells as well. This is exactly how next-gen antibody-drug conjugates, or ADCs, clear out those complex mixed tumors. The antibody binds to the target. The cell swallows it up through a process called endocytosis. The toxic payload is released inside, and then it diffuses right into the adjacent cells. It's essentially a molecular Trojan horse that destroys the biological fortress from the inside out, completely clearing out disease that older generations of drugs simply couldn't touch. Moving to Chapter 3: Immunotherapy, Printing a Custom Cure. Imagine being able to print a custom biological wanted poster, hand it directly to your immune system, and tell it exactly what to hunt down. Well, that's exactly what personalized mRNA cancer vaccines are doing today. And the speed of this therapeutic miracle is just breathtaking. Look at this 18 to 22-day turnaround. On day 1, the patient's unique tumor is sequenced. By day 8, an AI algorithm predicts the most visible mutations. On day 15, a completely custom mRNA molecule is synthesized. And by day 22, it's packaged and delivered to the clinic. We are literally manufacturing a custom cure for a single human being in under a month. No way could we have done this a decade ago. But you might be wondering, does this rapid customization actually work? 44%. In a massive trial for high-risk resected melanoma, patients who received this custom mRNA 4157 vaccine alongside the standard Keytruda immunotherapy saw a 44% reduction in the risk of recurrence or death. A massive, highly specific army of killer T cells is literally being trained to prevent the patient's own cancer from returning. And this brilliantly illustrates how these modern targeted approaches are reshaping even the toughest, most aggressive diseases. At the ASCO 2025 meeting, we saw practice-changing data for extensive-stage small cell lung cancer using a drug called Imdeltra. The median overall survival jumped to 13.6 months versus just 8.3 on the old standard of care. That is the first significant survival shift for this notoriously challenging cancer in years. A real game changer for sure. Chapter 4. The Alpha Emitter Upgrade. We've used radioactive isotopes for a long time, but we are now entering the final frontier of nuclear theranostics. Compare the old guard to the new. Historically, we used beta emitters like lutetium-177. They have a long range but lower energy, which means they frequently cause collateral damage to healthy surrounding cells. The massive upgrade here is targeted alpha therapy, using isotopes like actinium-225. Think of this as the difference between a scattered shotgun and a high-powered sniper rifle. Alpha emitters have a very short range but massive energy, thoroughly shattering the cancer's DNA while entirely sparing the healthy tissue right next door. Let's move to Chapter 5 and see how this builds into the future of cancer medicine. As incredible as these breakthroughs have been, the upcoming decade is gearing up to conquer challenges we once thought were biologically impossible. One of those massive challenges is simply manufacturing these incredibly delicate nanomedicines at scale without failing. The solution? AI digital twins. By creating a virtual replica of the manufacturing process, developers can predict batch outcomes and detect anomalies instantly. In one study, this technology dropped the batch rejection rate of lipid nanoparticles from 15% down to a mere 2%. We also have to consider the long-term environmental impact of this revolution. Let's look at the global warming potential of nanomedicines. Traditional lipid nanoparticles sit at 12.4 kilograms of CO2 equivalent. Gold nanoparticles, a staggering 387. But carrier-free natural product nanoparticles drop all the way down to 1.2. So, the future of medicine doesn't just have to be effective, it's actively moving toward environmentally responsible, sustainable designs. Clinically, the absolute holy grail we are racing toward right now is universal, off-the-shelf, and in vivo CAR-T generation. Imagine skipping the multi-million-dollar ex vivo cleanrooms entirely. The whole shebang, just bypassed. The goal is to simply inject targeted lipid nanoparticles directly into the patient's body, genetically reprogramming their T cells in real time, right there in their own bloodstream, to fight the cancer. And we're already seeing breakthroughs in active nanotherapeutics. Things like hafnium oxide radioenhancers, logic-gated sting activation, and ultra-small silicon nanoparticles that completely remodel the tumor microenvironment. These aren't just passive delivery trucks dropping off a chemical payload anymore. They are active therapeutic agents, uniquely engaging the body's biological pathways all on their own. The shift to active nanotherapeutics fundamentally changes how we evaluate and develop nanomedicines. We started this explainer with the horrific reality of a chemical weapon from World War I being used as our best line of defense. Today, we're engineering smart, self-therapeutic nanomedicines that actively collaborate with the human body's own intelligence to eradicate disease. So, what does this all mean? Which brings us right back to our opening mystery. As we permanently transition from blindly treating a cancer based on its geographic location to utilizing highly targeted therapies that literally rewrite its very biology, we have to wonder, what will the next decade of human innovation conquer? Thank you for exploring this phenomenal paradigm shift with me today. Keep wondering, keep learning, and I'll see you next time.